I request Dr. Uttam Chand to award a memento to Dr. Prakash GM and Dr. Mahalingappa B as a token of our appreciation.
Our next session is sponsored by Microlabs Limited. Innovative treatments and holistic approaches have made the reversal of many lifestyle disorders an increasingly attainable goal for the population. We have Dr. M.A. Shekhar, who will be presenting the topic, the reversal, remission of diabetes.
Our chairpersons for the next 3 sessions, Dr. Manjunath M., Dr. Hari Prasad S., and Dr. A. Ravikumar, please be seated on the dais.
Next, yeah. Above. Right. Okay. Should I start?
Dr. Shekhar doesn't need any introduction to anybody.
Thank
He's
you.
a lion in the field. Congratulate the organizer for selecting a very good subject and the best speakers in this field. Dr. Shekhar, sir.
Thank you, chairpersons. We'll start. I hope you are all hungry. And if I can continue for 2 more hours, you will lose at least 1 or 2 kgs. Maybe you can reverse your diabetes. Non-veg, fit and active. Veg, obese and lazy. You agree with this statement? We have been telling our patients to become vegetarians, but look at the animal kingdom. We are also a part of it. What do we learn from this? It's impossible to reduce weight by eating green grass and salads and walking for a long time. With this statement, you can refute me. Let me, for the next 14-15 minutes, tell you what it's going to happen. You all know what is type 2 diabetes. I am not going to talk about it. But 50% of your type 2 diabetics, if they have finished 8 to 10 years of their life, they need insulin. They become insulin deficient. Keep this in mind. Once they are significantly insulin deficient, nothing can be done. WHO, UK, diabetes, all of them have agreed long time ago, nearly 15-20 years ago, that you can reverse diabetes. And today everybody is jumping the hula hoop to say we can reverse diabetes. So let's take the first step and say you can reverse type 2 diabetes. In whom? Probably normal people. It's not there anyway. Let's look at it this way. This has been the fight for the last 3 years or 4 years, if I remember right, whether it should be called reversal, should be called remission, or it should be called resolution or cure. It has gone through all this. At the end of the day, the best phrase that you can use is remission of diabetes. For a common man, it is reversal. Or if you are an MA English graduate, it could be any word you want to use. Remission, reversal, blah, 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 it is okay. But how do you define remission or reversal? You must be very clear. Especially astute physicians should be very clear. I've given here HbA1c below targeted level, maintain for at least 6 months, up to 1 year probably, with or without continuing monotherapy. I have not written it, I'm sorry, but it should be lifestyle modification. But are we, when we talk about reversal, are we confident of telling these things to our patients? You have to be a little bit careful. Remission may be defined at metabolic, biochemical, clinical and pharmacological level. What is metabolic? No answers. Come on, guys. What is biochemical? You will all jump. Oh, FBS, PPBS, HbA1c, serum creatinine, blah, 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 blah. What is metabolic? I'll give you a concept. All of you have to give me 5,000 rupees. Clinical, we all know. Pharmacological remission is when your type 2 diabetic patients they do not need drugs. Characteristics that favor remission, in the upfront I'm going to tell you, successful weight loss. We'll come to how much. Short duration of diabetes and absence of complications. So now can you put this so-called successful remission and metabolic remission? You can look at that in a different manner. In other words, organospecific normalcy is metabolic, numbers is biochemical, feeling better, having less pain, neuropathic pain and probably vision problems is clinical, and no drug is pharmacological. Are we ready? So now you start telling your patients in this line. Metabolic, who decides? The doctor decides. Biochemical, who decides? The laboratory expert decides. Clinical, who decides? It's the patient, not the doctor. Pharmacological, both of you, whatever it is, okay? So biochemical remission may not always be synonymous with clinical well-being. Please be warned. Clinical well-being and biochemical remissions are not the same. Why? FBS below 100, what can happen? Hypoglycemia. Clinical well-being is not there. And one more funny thing that has happened with the reversal of diabetes is orthorexic state. What is orthorexic state? They stop eating. Just because their FBS is normal and PPBS is normal, they stop eating. 6 months later, they are multivitamin deficient, they have become frail, muscles are gone. Classic example was bariatric surgery. We'll talk about it later. So there were two phases. In 2009, it became very popular, and 2019 they revised. I'm not going deep into it. I can share my slides. You can read about it, especially the postgraduates. And I will request all the heads of the departments of medicine to have a subject seminar in their respective colleges about this. What's really important is you understand remission in a proper manner. Complete remission, partial remission, and IDF. You know, ADA looks at ideal condition for Americans. They always talk about sky high. IDF looks at all the three levels of countries: developed countries, developing countries, and underdeveloped countries. So IDF says optimization of metabolic state and sustained improvement of metabolic state. Substantial or sustained improvement, whatever you want to call it. But I just want to tell you people, please be warned before say, oh, don't worry, my dear fellow or my dear lady, I'll reverse your diabetes. Be very, very, very conversant with all these concepts. Metabolic, biochemical, clinical, pharmacological remission, substantial or substantive, metabolic state. All these things are here. I am not going to talk to you because everything is available on the textbooks or whatever it is. One thing that has come now is called as drug-sensitive remission. Once somebody tells reversal of type 2 diabetes, the patient is very happy, thinking that he or she will not be taking any drug, but drug-sensitive is monotherapy. With good lifestyle, good exercise, only one drug. Metformin was the first one in 2009 to be taken as drug sensitive, and today GLP-1 receptor analogs and SGLT2 are also included. Finally, I have just given you a gist. Are meaningful remissions possible in type 2 diabetes? Now that I have given you an idea, yes or no? Let's take a vote. Meaningful remission is possible? Say yes, I say. What I see, yes. Should this be a therapeutic approach? What do you people say? Should we say this is the therapeutic approach, not drugs, not exercise, not diet, or all of them together? Yes or no? Say yes. Thank you. 4 approaches. We agree there can be a meaningful remission of diabetes today, type 2. We agree that it should be a therapeutic option for majority of the type 2 diabetics who wish to cut down from 4 drugs to 2 drugs to 1 drug, etc. like that. But how do you do this? 4 approaches. Carbohydrate diets, low or very low carbohydrate diet, exercise and bariatric surgery. Today I am not talking about bariatric surgery or exercise. I'll just talk about diet. But before that, why diet is very important. You all know what is diet? You refer your type 2 diabetic to a dietitian or a nutritionist. We refer them to dietitian because diet is what we eat. Nutrition is what? What we are supposed to eat. That change, if it can come, it can happen. Let's talk about it later. You remember this twin cycle hypothesis, 2012 Banting lecture. Roy Taylor, who is not a physician, he's a nuclear physicist, a doctor by profession. He proposed this concept and it's picked up traction like anything. Twin cycle hypothesis. You see only one cycle here. Where is the twin cycle? Let me tell you this. Take this home, start working on this, all of us will do very well. Obesity, by definition, everybody says you look fat. But in clinical terms, obesity is 3 levels. Your so-called BMI or physical obesity, your so-called abdominal fat, that is visceral obesity, and so-called ectopic fat, that is intracellular obesity. So most of the Indians who have a pot belly are visceral obese, and many of the Indians who are thin are metabolically obese in the sense they have ectopic triglycerides inside the cell, all the cells. Cardiac cell, heart failure faster than diabetes. Kidney cells, kidney failure faster than diabetics. We'll talk about it later. But 2 important organs for our discussion for twin cycle hypothesis. One is liver, other one is the pancreas. The first place where it starts is in the liver. Ectopic deposition of triglycerides in the liver leads to what? Insulin resistance in the liver, hepatic insulin resistance. It translates into what? Fasting hyperglycemia. Then there is spillover, more fat liver has to manage, there is more VLDL produced, it gets transmitted and transported into most of the cells, and inside the pancreas they get insulin deficiency. Now you put it, now insulin resistance and insulin deficiency in type 2 diabetes, where is it occurring? For our discussion for reversal, it is in the liver and in the pancreas. Can any one of you tell me how much of liver triglyceride leads to hepatic insulin resistance and how much in the pancreas leads to insulin deficiency? Phase 1 loss. It's not in kgs, my dear fellows. 60 to 80 grams of triglycerides excess in the liver and probably in the pancreas, they become diabetics very fast. All you have to do is bring it down. How do you do that? Simple diet, simple concept. Thank you for appreciating me. Twin cycle hypothesis, the hierarchy of response is an early change in hepatic insulin sensitivity, that's normalization. Now can you go back? When you tell your diabetic patient, type 2 diabetic patient to lose weight, the first response you see is beautiful control of fasting states. Postprandial, whatever they are eating and less than things like that. But once the pancreatic conversion occurs, also postprandial. So fasting and postprandial response is mainly liver and pancreatic fat loss. How do you do that? Exercise, whatever that you are talking about. I am not going to talk much about all these things, but let me show you 2 pictures. How many of you remember this? One is in Ujre, other one is somewhere near Bangalore. Jindal and naturopathy in Ujre. They have been doing this concept for how many years now? As I know, more than 4 decades. as I know, more than 4 decades. I used to get calls from my patients who went to Ujre without my permission those days. I was an angry young man then. Now I am a mild old man. They used to call, sir, my blood sugar has come down to 70. They are saying stop tablets. They were already doing it. And now we say we can do it. So let's appreciate them first. But the major issue, can you understand, it cannot be forever. That's why therapeutic approach is something I'll tell you a little bit later. Very low energy diets, look ahead, direct study, power study, all those strong evidence-based medicine, let's not look at it. Low carbohydrate, you all remember? The Allen's diet before 1918. The only available diet was low calorie diet for diabetics at that time when there was no insulin, hardly any drugs. And today it is a very, very popular thing. I'm not going to talk much about that. But please keep this in mind. What is very low carbohydrate diet? 20 to 50 grams of carbohydrate per day. What is 20 to 50 grams of carbohydrate? 2 idlis. Whole day you have to eat 2 idlis. That is very low carbohydrate. If it is low carbohydrate diet, very low VLCD, low carbohydrate 130 grams, a little bit more. Moderate, all these things. So, can you convince yourself to tell your patient to eat 2 idlis a day and be done with it? I leave it to you. Bariatric surgery, let me not go there, but I'll give you 2 grading systems. You can always do it at home because plenty of diabetic patients who are obese go get the bariatric surgery and they come back and they don't eat the head of the surgeon who has operated, but they come and say, sir, I underwent, but it is not doing well. There are 2 grading system, diaram and ABCD. ABCD is age, BMI, C-peptide duration. You get it on Google. Don't bother about this. This is not a rocket science. But the major issue is diaram. They look at lesser the grading, better outcome. ABCD look at more the grading, better outcome. All you have to do it, put your patients through this and let's see what happens. Finally, ladies and gentlemen, is long-standing type 2 diabetes reversible? I said, is type 2 diabetes reversible? We all agreed. Long-standing, 10 years, you have to be a little bit careful. A 14-year, 15-year type 2 diabetic comes and says fasting is always beyond 140, 150. Don't jump into the hoop and say, I will reverse your diabetic. Is type 2 with normal or low BMI reversible? Normal type 2 diabetic comes, can you reverse it? There are claims, yes, if you can lose 7% of whatever normal weight, thin, what happens? You get a call from the lawyer, sir, you should come and give witness to what? Divorce. Wife is saying, my husband looks like a sickly person, I want a divorce. Be careful. What is the best diet to prevent weight gain? We have done, the patient has eaten only 2 idlis per day for the next 6 months and lost 15% of the weight and reversal has happened, very happy. What is that diet regime that you give which can lead to no regain of weight? It's a question mark. Finally, will diabetes come back? It's a remission. Surely it will come back if the patient lives longer. If the patient dies early, it will not come back. Very sarcastic answer I can give you. To summarize, meaningful remission is absolutely possible in type 2, shorter period. Should this be a therapeutic approach? I agree for certain, but with a pinch of salt you should take. Is there a lot of evidence for remission? Obviously. For against remission, as we stand today, there are no evidence-based medicine against remission today. But what is the therapeutic option? Individualize. You decide how you want to take your type 2 diabetic patient on the path to reversal of diabetes. And these are the references you want. Finally, I've used a classroom thing which I used to use it long time ago. 10th standard, still climbing. PUC, still climbing. And college, you think you have come to the top of the hill. But you look up, oh shit, life is still higher up. So we have, how do you say? We have really done remission of diabetes, but oh shit, it's not the final thing. Thank you.
Thank you, Dr. Shekhar. Is there any questions? So we'll move on to the next speaker.
Thank you, sir. Your talk was exceptional, and we greatly appreciate your time and efforts.
Maintaining a stable blood sugar level requires attention to both average glucose levels over time and fluctuations throughout the day. Our next speaker, Dr. L. Srinivas Murthy, will be presenting the topic HbA1c versus glycemic variability.
So, good afternoon, everybody. After Shekhar sir's batting like Richards, I may play like a gully cricketer, so please pardon me, don't compare with him. And I acknowledge presence of Chandraya sir, Murli sir, who are my teachers, who indebted to them always. It's always a privilege to be part of Kapicon. I think my task is very easy because to talk about HbA1c versus glycemic variability, which we tend to use day in and day out in our practice, but the glycemic variability part, I would like to emphasize the definition, where do you use, what are the factors which can influence it, and how do we apply that in our routine clinical practice. That is what is going to be my task. So these are my disclosures. When you talk about the glucocentric management, we need to take care of fasting PP plus the glycemic variability. That is what is the glucocentric approach in diabetes, what we talk about. And what is glycemic variability? It is a oscillations in blood glucose levels in a given day or inter-day, or three divisions we have glycemic variability, which I'm going to talk in the due course. It is a measurement of fluctuations of glucose or other related parameters of glucose homeostasis over a given interval of time. So this is what it is going to be. Just to show you this Monier et al. Very famous slide, which talks about the clinical scenarios where you have a A1C of two different patients and look at the glycemic variability. This itself will talk about the importance of glycemic variability, where it highlights the clinical scenario of these fluctuations, ups and downs. And again, this is again a Monier et al. Very famous slide, which talks about the contribution of FBS, PPBS in the overall HbA1c. As you can see, when it is below 8.4, it is mostly the postprandial hyperglycemia which contributes, and beyond that is your fasting basal hyperglycemia. So put together, the chronic sustained or the acute glycemic fluctuations which can happen, which most of us have had lunch just now, and this is what will result in excessive protein glycation and activated the oxidative stress and stimulates the cascade of inflammatory pathology, and of course the endothelial dysfunction will be the ultimate one. So we know A1C indirectly measures an average of blood glucose of 3 months. It has got advantages because it talks about a long period and it's widely used, accepted, easy, affordable. These are the plus points about A1C. As you can see on the right hand side in the graph, the fluctuations with this patient itself, 140 to 175 is the range the patient is fluctuating. And how do we have the evidence about A1C so far? It is based on the randomized clinical trials, where long-term follow-up of these trials clearly showed that the tight control would result in fewer microvascular complications. There is a definitive benefit about the microvascular, whether it is DCCT in type 1 or UKPDS, which is one of the longest studies, clearly proved us that the tight glycemic control reduced the risk of microvascular complications. And this is what we talk about the A1C targets in a given individual when they walk into the OPD, depending on the right hand side, the factors like risks associated with hypoglycemia, the disease duration, life expectancy, comorbidities, established or ASCVDs already present in that patient, patient preference, resources, and of course support system. Based on that, you take a call about fixing the A1C for a given individual, not 7 and below for every patient who walks into your OPD. Now, the limitations of A1C, of course, the conditions which can affect your RBCs, it can indirectly, like G6PD deficiency, erythropoietic drugs, blood transfusions, ESR disease, pregnancy, all these can, of course, there is a racial differences in A1Cs also, and of course, unreliable results in the presence of hemoglobinopathies, which is again undetected most of the times. So A1C is easy to measure but provides a limited insight into a given glucose profile of a patient. So there is a wide range of mean glucose variability which can correspond to 3 months, and the short-term glycemic variability or the hypo events can be missed in this, as you can see on the right hand side, with a high GV, high glycemic variability on the top A, and the subject B, subject 2 is low GV, you can see there, but eventually the A1C remains same in both the cases. So that's where we need to be careful, where the CGM matrix can help us to overcome this. So this is where the need of CGM comes into picture, and thus the glycemic variability. So the A1C values give no indications of the fluctuations, whether it's intraday or interday. And that is where you need to have the different patterns of glycemic variability through CGMs. And this differentiates the A1C advantages, disadvantages, and the CGM advantages and disadvantages. You can see affordable and near universal availability is something which makes A1C, which including me, we use it more and more, but there are niche indications for CGM in our practice, though even in limited resource settings, we need to be using it, and that is where we need to be thinking about. So first thing, when you see the glycemic variability, you need to rule out the root cause for the glycemic variability. That can be fixacious, lifestyle related, biomedical related, and pharmacological related. Now the first step is to exclude the fixacious, where you can audit the SMPG or the CGMs, which will give you that, the result that it is a fixacious, and you need to look at the instrument, the ancillary supplies, the sticks, expired sticks, many a times, all this you can look at. Lifestyle variability can be related to food, the exercise, the sleeping pattern, the psychological stress in a given individual. So these we need to take into factors to be considered. When it comes to the pharmacological variability, it can be due to the type of insulin used, the regimen what you use, the choice of preparations like the traditional sulfonylureas, immediate released, sustained release, etc. These can be one. Of course, the drug delivery, like injection in the lipodystrophic sites, where we know the absorption of insulin is erratic. And of course, tablet injection, meal time, the gaps between these two, all these definitely factors we need to counter in whenever you're talking about the pharmacological variability. So it may be possible that the chosen drug regimen, preparation or delivery device is not appropriate for that particular patient. So this you need to remember. For example, the basal insulin regimens to a person with a predominant hyperglycemia, and using human insulins rather than analog insulins in such situations can lead on to the variability in the glycemia. And of course, the biomedical causes, what we mean is the gastrointestinal, which can be diabetic gastroparesis, malabsorptions, and the neuroendocrine causes, where the autonomic nervous system involvement, again because of that long-standing diabetes, and the pancreatic, both exocrine enzyme deficiencies can also induce these abnormalities, and the PKPD properties of a given drug can also involve. Now, how do you evaluate the glycemic variability as per the time frames? It can be short-term, that is -1 to 3 days, 3 to 1 month, and 1 month and beyond, which is short-term, intermediate, and long-term glycemic variability. Now, the question comes, why should we bother about the glycemic variability? Why, when we get HbA1c, which is real time and very easily available, affordable? It's because we know the impact of short-term glycemic variability reduction on cognitive functions. This is something which most of us neglect. We never evaluate with the scores available, and this can be information processing, working memory, and attention span can be very low in these individuals, and the rate of change of post-meal blood glucose may correlate with the depressive and anxious mood and symptoms of cognitive dysfunction, and hedonic tone and energetic, that means feeling of happiness, feeling good, feeling alertness, is something which again gets affected. And of course, the impact of short-term GV on quality of life and adherence, there is an evidence. This is a type 2 diabetes, about 54 patients initiating insulin pump. They clearly showed that control of short-term changes in the blood glucose has an important effect on patients' day-to-day life and may contribute to a positive feedback loop of improved glycemic control with a better treatment adherence and improvement in the quality of life. And of course, the glycemic variability with the risk of hypoglycemia is we know HbA1c is a poor indicator of hypoglycemic episodes. We saw that in the Monier et al. Slides, because it only accounts for 8% of the probability of severe. That is the prediction value that we are talking about. But whereas in the glycemic variability, it can account estimated 40 to 50% of the future hypoglycemic episodes. 8% versus 50%. That is the importance of glycemic variability. By studying this, you can have over 50% can be predicted from the analysis of this variability of self-monitored plasma glucose over time. And of course, the hypoglycemia, the impact on the elderly patients is definitely much, much worse compared to young. We know the symptomatic response to hypoglycemia are generated at a blood glucose level that is higher than the level where the cognitive function becomes impaired in the youngsters. It is vice versa in the elderly, and that is where we need to be careful about monitoring this glycemic variability in the elderly population. And clearly, the multivariate analysis has shown the independent determinants of CAD. You can see there, and the MAGE events, you can see the glycemic excursion is an independent risk factor for CAD. That's very, very important to remember. It is going to be an independent predictor for CAD. And of course, the adverse clinical outcomes because of glycemic variability can be hyper and hypo, and they stimulate the cascade of inflammation. And of course, the endothelial dysfunction eventually resulting in the macro and microvascular complications. So, the impact of glycemic variability, when you assess it and talk and alert the patient about the high or low variations, it can reduce the fluctuations by improving the awareness of this hypo or hyperglycemia to the patient. Many of us, our patients will not be about, especially about the early morning or the late night hypoglycemias. And the significant GV increases the need for more frequent glucose monitoring, where they'll become conscious, alert, and of course the health provider contact, they do that whenever they recognize that there is an episode of hypoglycemia which is mostly asymptomatic. So to summarize, the glycemic variability management can improve the quality of life, complication prevention, patient awareness, and of course the cognitive functions. Now some evidences to show whatever statements we made. This is an effect of intensive glucose lowering in type 2 diabetes. This is about an ACCORD trial which clearly showed the mean A1C and the risk of heart failure in patients with long-term variability. Have clearly shown the highest quintile of A1C variability had approximately two-fold higher risk of heart failure when compared with those in the lowest quintile. That's something to remember. And of course, the long-term glycemic variability, risk of adverse outcomes. This is a meta-analysis of 13 studies in diabetics where higher A1C variability was associated with the higher risk of renal disease, macrovascular complications, ulcerations, and of course CV disease and mortality. So the short-term variability is, of course, we know it's a rapid within or between day upward and downward fluctuations. Parameters in the CGM like mean amplitude of glycemic excursion, we call MAGE, and the MOD, that is the mean of daily differences, can be very easily to recognize and represent and to educate patients can be utilized, and these parameters are calculated on the CGM, of course. Now again, to show activation of oxidative stress by acute glucose fluctuations compared with sustained chronic hyperglycemia would result in the complications. Hyperglycemic spikes following every meal induce the oxidative stress, inflammatory reactions, and endothelial dysfunction. This is something to be emphasized to the patients, and we show them the spikes. They clearly understand this in a pictorial manner. And of course, it's a strong predictor of mortality in critically ill patients as well. And of course, the advanced trial clearly showed us that the fasting glycemic variability was associated with the both macro and microvascular events, and the A1C variability was positively associated with the risk of macrovascular events. Visit-to-visit variability of glycemia and vascular complications, the hormone diabetes care system cohort showed that the highest coefficient of variation in the first 5-year interval showed the increased risk of insulin initiation, retinopathy, macrovascular complications, and mortality as well. And of course, ACCORD established that the attempting to achieve too much tight control can result in increased frequency in the CV events because of the severe hypoglycemias. And DEVOTE 2 was a comparison between the glargine and the degludec. And this study reported association of day-to-day fasting glycemic variability by SMBG with severe hypoglycemia and cardiovascular outcomes. And that is what you should remember. And this is about the DIAMOND randomized clinical trial in type 1s with insulin injections. They found that the CGM users achieved a significant improvement in the A1C levels from 8.6 to 7 versus that is a coefficient of variation from 42 to 38%, which is a significant statistically. And of course, in diabetics, this is another evidence just to show that long-term glycemic variability and risk of adverse outcomes is meta-analysis of 13 studies again showing the variability is related to renal disease, macro cardiovascular components. And of course, short-term glycemic variability does not only consist of the downward glucose, but also the result of upward postprandial excursions. Therefore, one of the remaining questions is to quantify the contribution of these postprandial glucose increments to the overall glycemic variability. You should remember that as well. It is not only short. And clearly, lowering the glycemic variability has improved the quality of life as shown with respect to the work productivity, absenteeism, or treatment satisfaction. And of course, numerous studies have clearly shown that the obscure effect of depression in the evolution of diabetes, especially when the comorbidities of complications exist, and that again we need to keep in mind, and glycemic variability improvement can lessen that. So which patient should be evaluated for glycemic variability. We are talking so much about that. These are the patients where when you have a suspicion about insulin deficiency, calorie intake, presence of gastroparesis, late or missed administration of insulin at meal time, irregular snacking, errors in basal insulin administration, clinical necessity of an insulin pump. To study this, you can have a glycemic variability as a baseline, and this will definitely help us. And also to identify patient characteristics whenever there is a prevailing fasting or postprandial hyperglycemias, where patients with the prevailing insulin resistance or insulin deficiency, when you're suspecting oral or insulin mixed therapies, and at risk of hypoglycemias, long history, elderly patients, these are the set of patients where the glycemic variability may be limited in younger patients owing to their considerable function reserve. And of course, CGM, insulin treated individuals, pregnant women, diabetes and intensive insulin therapy, poorly managed diabetes from understanding the influence of diet activity and medication on glycemic management. Again, indications for the CGM, type 1 not meeting the A1C targets, patients with repeated hypo episodes, hypoglycemia unawareness, subjects requiring better glycemic control while avoiding the hypos, before or during pregnancy in type 1 or type 2, need for improving brittle diabetes when we face a lot of problems in controlling them. Now, how do you evaluate? This is just to show the serum markers of glycemic variability, not routinely done in clinical practice, but in clinical trials we do these, especially the glycated albumin hemoglobin ratio is one of the commonest used. And of course, the glycated albumin also gives that. In addition to these indices, simple markers of glycemia can be this glycated albumin. And of course, in CGM, what are the factors you look at? I'm sure all of you are aware about this. Just to show the glycemic variability indices are these: standard deviation, MAGE, and coefficient of variation is something which we use routinely. Mod of mean of daily difference also is taken into account, and the CONG is continuous overall net glycemic action. And this is again many times we use in the trials and the publications. Now, to summarize, the globally CGM studies have clearly shown that the recommendation is there for diabetes management of CGMs, and CGM clearly has got upper hand in improving the glycemic control versus A1C. This is again evidence to show that the patients who look at CGM display have got a better control of the sugars rather than looking at only the A1C. And you can see the meta-analysis of CGM trials in type 1 and type 2 diabetes here, the change in A1C and time in target glucose range, that is TAR what we call. And how do you manage? End of the day, you diagnose this, and where do you do that? Obviously, it has to be through various approaches. The first one has to be dietary approach, which most of us neglect in our routine clinical practice, to emphasize the importance of diet and exercise. Structured educational activity on the carbohydrate contents of various foods, diabetic and obese patients using meal replacements, and preferred diet, unrefined foods, rich in fiber, high in vegetables. These are the factors which we should emphasize. And of course, in addition, the vinegar, the fish oil, the tea, cinnamon, etc. to be emphasized. And of course, the smoking and alcohol has to be absolutely stopped, and that is something which you should emphasize when you are counseling your patients. And of course, the physical activity, we don't practice, we don't preach. Many of us, that is the logo, I mean the motto most of us we use, but the low medium intensity exercises should be promoted, which we know that consumes the excess fatty acids. Exercise alone enhances the effects of oral OHAs, and physical activity often promotes or triggers hypoglycemia in subjects with diabetes who are receiving the OHAs. Availability of new hypoglycemic agents with greater glucose dependence and lower hypo risk simplifies the recommendation of physical activity with a greater adherence. This is something which we should utilize, and case-to-case basis we need to take a call on the treatment aspect. And of course, components of glycemic control in clinical practice should include the glycemic exposure, the metabolic compensation resulting in between the glycemic variability and the exposure, and the A1C, and of course the PPG, FPG, which we commonly use, the choice of therapies. And treatment decisions based on the blood glucose excursions have to be mainly based on the fasting or the postprandial hyperglycemia, and the anti-diabetic modalities has to be based on these two these two factors. And the traditional choices, metformin, TZDs, AGAs, magnetides, do work well in our country. DPP4s, GLP-1s are something which are safer, which are definitely to be used in most of our patients, including the SGLT2, case-to-case basis again. Analogs, basal and prandial insulins, pumps, etc. will definitely address the CV, the GV effectively. To conclude, A1C, it's a measure of sustained hyperglycemia, has been the main target to assess response to diabetes treatment and positive association between a poor glycemic control and the outcomes. And in recent years, increasing information indicates that the short-term and long-term glycemic fluctuations have a greater deleterious effects on the development of diabetic complications. Hence, the clinical studies clearly demonstrate the glucose fluctuations are associated with these micro and macrovascular complications. And To summarize, the glucocentric point of view, you need to consider, apart from your FBS, PPBS, the glycemic variability. First, evaluate the root cause of the glycemic variability, which can be fixations, lifestyle, exercise, pharmacotherapy, or biomedical. And the glycemic variability can affect cognition, quality of life, which can be associated with the micro and macrovascular complications and reduced treatment satisfaction and adherence as well. And you need to focus on prevention of glycemic variability through dietary approach, physical activity, and pharmacotherapy approach. Thank you very much for the patient hearing, and any questions we'll be very happy to take it up.